Welcome everyone to the June 2019 Patient Safety Webinar. We're so excited all of you could join us today. It is my pleasure to introduce today's speaker, Dena Silva. Dena started at UNT Health Science Center as program manager, bringing with her experience as a trainer and educator. She was promoted to director of INCEDO in late 2018 and facilitates the overall strategy and design of UNT HSC's continuous professional development program and the learning experiences for its participants. As a member of the Society for Academic CME, Dena sits on the Communications Committee and is involved in the ongoing management of its website. She holds an MS in Learning Technologies and specializes in bridging the technology gap in education through online learning activities, LMS implementation and oversight, as well as website content and infrastructure. Dena is actually sitting here in the room with us today, and we're so excited to have her here. Let me just make sure her presentation is showing correctly so we can get her started with that. Sorry about this, Dena, just a moment. Apologies for the technical difficulties, everyone. We'll get this loaded in just a moment so Dena can start her presentation.
While she's doing that, I'll go ahead and ask the question I had plugged in a little later, but I'd like to tailor this a little bit to the participants that are here. So if you all wouldn't mind putting in the chat box what type of organization you're with or in what way you might work with a continuing education professional.
You guys can go ahead and feel free to use the chat box to answer that question from Dena. You can put your answers in there. It should be default send to everyone.
Wonderful. Seeing a lot of great responses. Oh, an AHEC, great. Oh, wonderful, a community college. I was just reading something about needing to do more research about the influence that community colleges have in the healthcare professions. A lot of community colleges really get us going and really have strong programs that feed into either graduates themselves or feed into longer developed programs for medicine, nursing. That's great.
Okay, we seem to have an issue with the PowerPoint, so I'm going to go ahead and just live share this for you all. There we go. All right.
Great job.
Take it away, Dena.
So my presentation is focused today on what problem are we trying to solve and how continuing education professionals can help close the gap. I'm
going to do it for you.
Oh, you're going to? Oh, bless you. So every great webinar presentation you've ever been to, especially in the continuing education world, starts with the learning objectives, the standard. So this is the tried and true way. So by the end of the session today, I'd like you to be able to describe the role of a continuing education professional, identify 3 ways continuing education can close a patient safety gap, and describe innovative approaches to improve healthcare outcomes. So when you're designing a continuing education activity, you will get asked for these objectives, whether it be for the program as a whole or for the session you are offering. And this is part of what problem we need to solve collaboratively and collectively begins, because most healthcare professionals do not know how to write learning objectives, but we as continuing education professionals do. So as a part of pulling back the curtain today, I'd like us to get to start thinking about how we each play a role in help launching these educational activities. I saw a lot of you are librarians, and we work a lot with medical librarians to be able to pull the resources and information to actually actually write the learning objectives. So again, you play a large role in developing and delivering meaningful continuing education activities. But instead of just focusing on the standard of learning objectives, I also like to think in a part of solving the problem, we go to learning behaviors. So this is the next piece in taking your learning and designing to a different level. Because objectives are important to the learner. They help establish and quantify what they're going to learn today. But when you're developing and designing the activity, you really want to think about what behavior the participant is going to walk away with. So one of the things I'd like for you to do is develop a positive awareness around, I'm starting very low bar here for behavior, really just developing a positive awareness of the role that continuing education professionals bring in developing and designing continuing education activities. And then I'd like for you to be able to walk into your continuing education office equipped to collaboratively and develop an educational activity for healthcare professions. So I want you to know, but more importantly, I want you to do. And sometimes that's difficult to get across during webinars, but if there's anything during the presentation that you'd like me to address, please put it in the chat box. Let's have a conversation today. So why do we provide accredited continuing education? And the biggest reason is to provide a safe space for learning without influence. A lot of healthcare professionals have side jobs, and they are connected to pharmaceutical industries. They are connected to monetized ways of providing influence or bias into a continuing education activity. So through the process of becoming an accredited continuing education provider, we write policies and procedures and subscribe to standards that help us eliminate bias from the learning place. So continuing education healthcare professionals know all of the ways in which the speakers are paid or not paid to develop the content that they create for a CE activity. We ask for this information before they're permitted to speak or provide content. Continuing education offices vet them to determine that they have the credibility to speak on a subject and that they're not connected to any payments that would influence their ability to speak on the subject. So that's one of the primary reasons that accredited continuing education exists. Of course, with this, over time has come rules and regulations or for maintenance of certification for regulatory bodies to say that they need to have continuing education hours to maintain their licenses, to belong to a certain society or organization, but it is our primary job to provide a safe space without influence. We are also playing a large role in when states are providing rules or regulations towards providing continuing education on opioids, HIV, ethics. There are a lot of states that require us to offer continuing education on specific topics. So that's another reason why it's a part of this whole accreditation process so that we are guaranteeing that the professionals are receiving a high bar level of education. Healthcare information is rapidly changing. The estimate is approximately every 72 days there's new healthcare information. So it's vital that our healthcare professionals adopt a mindset of lifelong learning, and accredited continuing education helps feed that lifelong learning. One of the things with accreditation, though, that I hear a lot is that the requirements vary. So I wanted to explain a little bit why when you deal with one provider, the rules and information might be very different from when you work with a different provider. The Accreditation Council for CME, the ACCME, has approximately 1,642 registered providers in their database. We are evaluated on our ability to produce policies and procedures for 12 different sets of criteria for maintaining accredited continuing education. Accredited CME providers can be at hospitals, they can be at academic medical centers, they can be a medical education company, which is usually a for-profit organization that designs and develops continuing education. The criteria that we're evaluated on include documenting needs assessment data, determining appropriate learning formats or interventions based on that data, commercial support independence, and then also the analysis of outcomes achieved. So every provider, so 1,642 providers, are developing policies and procedures that fit the needs of their organization to meet those 12 different criteria. So when you start thinking about how many organizations there are, the different types of organizations there are, you can see why the rules that accredited providers put into place significantly vary, and it can be incredibly frustrating as the consumer, I imagine, to request continuing education from one organization and then go to a different organization and have different rules or different application of policies. And then you think about that this is only for continuing medical education, which is only one of the healthcare professions. And as interprofessional continuing education or interprofessional education within the healthcare professions continues to grow, planning an accredited activity for multiple professionals can look a little bit like this. Our office houses 8 different accreditations for various healthcare professions, and sometimes this is a little bit what our documentation looks like as well. And it can get confusing. So I wanted to say that I empathize with people who are trying to plan because it can get convoluted. It is our job as continuing education professionals to help make this process seamless. I would say that that's not the attitude that every one of the offices has, but in our office we really try to be the accreditation specialists and work with you within your subject matter expertise. Every continuing education office is a little bit different, and depending on the size of the office, you may have very different skill sets or abilities housed within that office. One of our industry organizations, the Alliance for Continuing Education in Healthcare Professions, has developed competencies for a continuing education professional, and they have developed this curriculum structure for those of us that are in CE offices to be able to provide training to our employees or even to people who we work with in the continuing education office to be able to establish some normalized approach to defining a continuing education professional. One of the things to keep in mind is that CE industry in its current form has only been around since about the 1980s. So we're still a relatively new industry considering how long healthcare professions have been around. And even since 1980 through the mid-90s, there was significant influence from the pharmaceutical companies in bias and misinformation around how to provide accredited continuing education. We've definitely reformed ourselves and aligned with the standards of commercial support and provide that bias-free learning space. But as an industry, we continue to really identify our profession and what it means to be a continuing education professional. And so then we'll go to the next slide where we'll deep dive into these pieces a little bit more. The core 4 products of a continuing education professional are knowledge of the healthcare landscape, the adult learning principles, education design, and accreditation. With the core and the awareness of healthcare and continuous professional development landscape, this includes the continuum of healthcare professionals. It also looks at the issues related to coordination of care across systems and barriers for learning and application within the healthcare environment. When we look at reviewing the continuum, this is very important because what is going on in undergraduate medical education and graduate medical education directly influences our learners within the next 5 to 10 years. So for instance, many medical schools are adopting flipped classroom approaches with group learning. Therefore, what is a CME program going to look like when those learners get out of residency and are they looking for the conferences with a stage on a stage? Do they want all online learning? How can we adapt what continuing education offerings are based on what the students are receiving in undergraduate and graduate medical education? CE professionals also have to have a deep understanding of adult learning principles with the knowledge of potential interventions and overall activity planning, including the identification of practice gaps and outcomes assessment. Adult learning principles also take on a slight variation when dealing with healthcare professionals. We have such high energy students in our world. They are very good self-directed learners, and they have high demands, and so we have to adapt the adult learning principles slightly for the rigorous training that our learners have already gone through to get to the point of needing continuing education. A CE professional must also be able to design and develop activities to address practice gaps and execute them across accreditation, regulatory, office policies, and procedures. So there is a high level of compliance in our job as well, and you have to have that eye for detail and making sure that you are addressing the needs that have been and expectations that have been put upon us by our accreditation bodies. And from here, the CE offices have they may have very specialized positions, or they might have generalists that address some of these other areas. Again, this is one of the things that can add to, I hate to say it, but frustration in dealing with continuing education is one office might have 17 people in it that are highly specialized. They have their outcomes people, they have their quality improvement people, or you might be dealing with an office of 2 that are generalists and they have a broad scope of knowledge but not specialized. But here's some of these specialized areas within continuing education. Program management. This is the skill set necessary to follow best practices, including financial planning and communication skills, the utilization of technology for moving a project forward, and articulating the goal to stakeholders. So we actually are required by our accrediting bodies to provide financial reconciliation. This goes into figuring out the bias that may or may not be present. If a payment was received by someone and we weren't made aware of it, it could potentially influence the content that was provided in that meeting and session. So I think whenever we dig into the finances of an activity, it surprises people, but that's the primary reason behind it. The next area is measurement and evaluation, and this includes an awareness for different models of evaluation, the ability to determine levels of outcome appropriate for the gaps in interventions, as well as recommendations for appropriate sources of data for measurement. If you're in a management position, you also have to have the skill set to evaluate the program as a whole to determine if your department is effectively moving CE forward. And I say that meaning organization specific. Are you moving continuing education forward within your organization? And the next one, leadership, it isn't just reserved for those managing the team. It is asked of every team member. There's a lot that goes into planning and orchestrating a continuing education program, and especially when working with healthcare professionals, actually any professional these days, we're all so busy. It takes a skill set for advancing that forward. Establishing effective partnerships is imperative to the success of a CE department, and therefore each team member must display leadership qualities. We also have to engage in our own self-assessment. As I said, medical knowledge is changing every 72 days. Continuing education programs are at really the intersection of 2 highly evolving industries, healthcare and usually including some level of higher education. And if we're not assessing our own knowledge against the changes of both of those industries, we will fall behind and we won't be able to produce meaningful educational activities for our healthcare professions. The next is quality improvement with strategies for continuing education becoming more personalized and provider-specific. Professionals are having to branch into collaboration more with quality and performance improvement. Again, depending on the office you're working with, this may be included within the structure of the office, or it may be a partnership that they collaborate with. But we've been charged by our accrediting bodies to make continuing education a more personalized experience. So really rooting down into what are the individualized needs of the learner and where are they at today and where do we need them to be. A specialist in this area would be able to define effective strategies for improvement collecting data for reviewing baseline and improvements, collaborating with clinicians on possible interventions, and opportunities for system-based improvements to run parallel to enhance learning. Outcomes assessment and reports to learners in a meaningful visualization. And data visualization is an entire specialist. It's if you haven't done much research on data visualization, I encourage you to look through it, because the way we discuss our improvements makes for a great story, and the visualizations you choose to demonstrate those movements make an impact. Interprofessional education, as more undergraduate schools are designing interprofessional curriculum, these students are arriving to professional work environments that have not yet embraced interprofessional practice. The CE industry absorbs the responsibility for teaching them interprofessionally and having our industry collaborate across healthcare silos. Helping professionals see the competencies that can be addressed in other professions is vital to the success of planning interprofessional activities. So again, like I mentioned, our office has 8 different accreditations, and we have a crosswalk of competencies so that we're able to be able to apply what's applicable to one competency in one profession is also this competency in this profession, and so on and so forth, so that we can make sure that we're doing our best to go from just offering multi-accredited activities to truly interprofessionally planned and delivered activities. A separate area of specialists is grants and industry support. The continuing education industry still relies heavily on industry support for financial operations, and we must have an awareness of how the grant system works, the role of support, grant management from submission to grant outcomes. And I work in an academic healthcare system or healthcare setting, and even the grants we write are slightly different than you would write. It's kind of the difference between writing a foundation grant versus an NIH grant. Well, then there are continuing education grants, and while they may have similar titles, the components that are underneath the structure of each of those titles vary from what you would do. So again, even a grant writer within the continuing education industry has a certain specialty than those that would write NIH or foundation grants. For evolving and emerging trends, as I mentioned, we're at the intersection of 2 very rapidly changing industries, and regulations are also always evolving and impacting the practice setting that our healthcare professionals work in. So new rules are put into place, payment or delivery care models impact patient outcomes. Patients are becoming more involved in their healthcare and researching their care more than ever before, and therefore this is really challenging clinicians' abilities to explain their decision making. So we find that we have to incorporate a communication component into a lot of our clinical learning, because clinicians are having to explain themselves more and more in their practice to patients every day. Data is also informing care more and more, and as we continue to embrace artificial intelligence in healthcare, what a physician needs to know to be a provider of care will shift significantly. And CE offices really have to incorporate this into planning for meaningful activities. Technology is a separate element, and utilizing, as we expressed in the introduction, I have learning management implementation background, and the utilization of a learning management system has really only come into the continuing education industry in the last 10 years or so, and it's still not adopted by every continuing education office out there. And so we use the learning management system to record and track participation within our activities, evaluation data, and so in the last 10 years, continuing education professionals have had to add a significant level of technological skill sets to their repertoire to be able to keep up with the industry. This also includes the interacting with the user experience in online modules and the providers using an EMR to record their activities. So continuing education professionals have to ask questions about how are you utilizing the EMR, because otherwise we won't be able to get to our healthcare outcomes. The next is research and scholarship. So I think like every industry, we want to continuously prove that we're making a difference, and that requires research and scholarship. So to prove our value and disseminate that value to others, we are conducting more and more research activities with regards to how learning activities are changing patient outcomes, and trying to demonstrate those effective strategies to really transform our industry. So that's us in a nutshell. But how does knowing about who we are, what we do, what we bring to the table help you really plan more effective activities? So now we're going to transition just a little bit into, does anybody have any questions in terms of what we just reviewed? I know it's kind of straightforward, just delivery of information.
And for those of you wanting to enter questions into the chat box, you can reopen the chat box by using the drop-down menu at the top of your screen and clicking on chat, and you can answer your questions there.
Great. I'll go ahead and move on. So the ultimate goal for continuing education is closing the gap. The gap between what is and what should be. And I love that I found this visualization and wrote continuing education. It's the continuing education ladder. So when you walk into our office and say, I want to hold a program, and typically this is actually what still happens. So as much as we know about effective learning design, educational design, we have instructional designers, what we still see a lot of is a clinician walking to our office and says, we need to have a program about this. So I'm going to ask you to back it up a little bit and say that this is how we should approach this situation. We should be asking you, what does the desired performance look like? What is the behavior that you want them doing at the end of the activity? This is identifying the gap, that gap between what is and what should be. And through this discussion, we need to determine what type of gap this is. Because you walk into our office and you say, oh, this isn't happening and we need this to be happening. Sometimes that gap is not an education gap. And if the continuing education office is doing their assessment and really identifying the gap, it might be a systems issue. It might be a workflow issue. So we might not be talking about truly a continuing education activity. If the gap is established, then you then need to assess the current state of affairs. So finding the baseline through performance measures, through research of literature, hint, hint, surveys. You can survey your workplace, survey the clinicians that work there to find out how big or small the gap is. So then you proceed to designing the experience for the desired outcomes, which is really easy to write in those tiny words, but then you bring into what kind of outcomes are we actually looking for the continuing education activity to bring to the table. And so what the CE office use is the Moore, Green, and Gala's outcome scale. It's a 7-point scale, and yes, most educators use Kirkpatrick, but the difference between what we have in this is to bring in the patient outcomes, because ultimately our goal for continuing education activities should be patient or community health. Now, those are really hard outcomes to achieve. So we work up the ladder from there, but we start with participation, which is quite frankly, where there are people there. If a tree falls in the wood and no one's there, doesn't make a sound. If you hold a CE activity and no one comes to it, yeah, did it happen? And so participation is still an important outcome, but it is the lowest level of outcome that we have for our programs. Satisfaction is the next level, and it includes rating on if they felt the activity met their needs. This is obviously a little bit up to them, but this all goes into how did you market the activity? Were your learning objectives really in line with the information that was distributed? So it could be an evaluation on what your planning looked like versus what your execution looks like. And then learning is the next level, and it can be obtained through collection or testing of self-report This is really, you know, what did they say? This is more like a checkbox of, did you learn at this activity, yes or no? That is the level of this learning outcome. Level 4, or competence, is when it starts to get interesting. So competence is the demonstration of how to do in a learning setting. And we'll go into this a little bit in the next couple of slides. Performance, or level 5, is the demonstration of what to do in a practice setting. Again, we'll differentiate those in a second. But level 5 begins the involvement of baseline data from the EMR, from patient chart reviews, that truly demonstrate that the provider is applying the attentions of the learning in the activity to practice. Level 6 would be patient health, which includes results from level 5 in the degree of an improvement with the health status of the patient, which would then lead to level 7, or community health, demonstrating that an entire population of patients were displaying improvements. So how do we know which level is achievable based on the gap? This is through the evaluation of the needs assessment, which should identify what type of gap is occurring and therefore designing the learning activity appropriate to closing the gap. So again, if you're seeing something that's truly a patient health issue, then you should take a hard look at how you're designing the activity. So if it is a knowledge gap where, so a knowledge gap is where the information is unknown. With adult learners, a knowledge gap can also mean that previous information needs to be unlearned. So just keep that in mind. Adult learners tend to stick information either into places it doesn't need to be, or they attach it to wrong information and they hold on to it for dear life. So I've actually found that a lot of adult learning in healthcare professions is unlearning old information. You can look at the use of antibiotics for appendicitis. You know, it was previously that you did surgery for appendicitis, and then they started doing smaller the word's escaping me because I'm not a clinician. And then now antibiotics for appendicitis is the emerging treatment guideline. So you have to unlearn what you previously knew. So in this picture, I've demonstrated showing a guitar proper placement. I had to guess if proper placement because among not being a clinician, I'm also not a guitar player, so hopefully the stock photo did not steer me wrong. But this could be the first time they've ever picked up a guitar. It could be that they were taught as a kid but forgot it all. It could be that they are self-taught and made their fingers work however they wanted to. But until we assess our learners for where they are at, we will not know where to begin. So this goes into the meaningfulness of the activity itself. You can plan the best conference, you can plan the best online activity, but unless you truly know where your learners are at and what they can gain from this activity, is it a meaningful activity? So for a knowledge-based activity, you can present a didactic presentation, but we do know from research and dissemination of the research that when active learning strategies are utilized, learning is enhanced. So adding in polling questions, pair and share are effective strategies to incorporate and enhance. Newer strategies for knowledge-based also include micro-learning through podcasts, and so really stretch, because disseminating knowledge can be really easy to your learners, and it can be quick and in a way, in a format that they are going to laparoscopic. Thank you, Karen. I just noticed that. I really appreciate that. For the next one is competency. So competency is the ability to demonstrate proper application of knowledge within a learning setting. So you can see in this picture, she's built in her practice setting. She's applying what she learned from the lessons, but she's no longer being hands-on taught the chords, but demonstrating the song. So this, in competence, allows for the observation and feedback to improve in a safe environment. So educational strategies that demonstrate improved competency include simulation with augmented or virtual reality, the use of standardized patients or case studies delivered within an online module, or even results through an audience response system. And enhancements to these would also to have the person deliberate the barriers that could exist from having them implement into practice. So they're learning, they're experiencing, and they're already determining what barriers need to be overcome when they get back into their practice. So competency-based education is a great way to build team performance, as well as check for conscious or unconscious blocks to learning. Many experts can't recall the steps it takes for them to complete an action, so by having them perform it outside of the practice environment within the learning setting, it can slow them down, allow for questions, check for understanding from the learners. The next is the performance. So this is the rock and roll show where it all comes together. And the goal of a performance activity is to demonstrate within actual practice that improvements are occurring. This can be in the form of a maintenance of certification activity, workplace learning, and can be observed through medical records, patient surveys, lab reporting, quality reporting, all of those things that actually demonstrate that that the learning is taking place in the practice setting. And this is where we achieve some of those higher level outcomes, because you can't get to the higher level outcomes until you start seeing the differences in practice. So the next thing I promised to talk about were some innovative approaches to continuing education. And I actually stuck this in at the end, but I think I want to talk about it first because it's really important to me when we're talking about innovation that we don't start comparing ourselves to others. Innovation comes one step at a time. And so it's really challenging what's going on within your learning context, within your learning environment, and taking it to that next step. It's not about hearing about somebody's innovative project and trying to implement it within your own environment. Effective continuing education within an organization happens when you do what is best for the organization. So I just want to preface that instead of following it up with that so that you don't hear the next couple of slides going in a context that checks you out. So one of our programs that we've conducted is called Asthma 411, and it is a comprehensive approach to patient safety. Asthma is very prevalent in our county, higher than state and nationwide. So our problem that we were trying to solve was keeping kids in school, because asthma exacerbations were really starting to harm our absenteeism in our local school district. So, and when you have an exacerbation, it can keep you out of school for several days. So the educational problem was multi-pronged. Schools needed to know about the signs and symptoms of respiratory distress to send the children to the nurse's office faster. School nurses needed a district-wide training on managing respiratory distress, and healthcare providers needed education on completing asthma action plans for schools, because when we started meeting with the school nurses, we found that providers were not sending asthma action plans to the schools. And throughout the course of the program, we also found that they weren't prescribing 2 inhalers. So there was a lot of education that needed to be provided. We initiated the program through a continuing education grant from Pfizer, which allowed us to incorporate training into the schools. We took a systems-based approach to this project to equip the schools with nebulized albuterol so that in the event of a respiratory distress, the student could receive their rescue medication if they did not have an inhaler at school. Over the course of a 2-year pilot program at the schools, and again, 1 year we did for baseline observation, and then the 2nd year we implemented the program, asthma absences were reduced by 51%. Since we've had such success with this program, we've rolled out to countywide, and we have about 350,000 kids receiving the benefits of this program. Through Safer Care Texas and a collaboration with local hospitals, the countywide school nurse training program occurs annually, and we also host a learning collaborative for district health administrators to help continue to contribute to the design thinking approach for how do we continuously up our game. And it's not just, here's the program, we did it once, we're done. We're continuously evaluating the data we are receiving from the school districts to find out what our next opportunities for training the school nurses or training the school districts. And teachers also have a continuing education requirement, and one of the things over the next year or so that we'd like to incorporate is actually working with the physical education teachers, because they are conducting activities on high alert ozone days and really getting the asthma children, or even those that aren't yet diagnosed with asthma, into respiratory distress, and again, having those multiple absenteeism. But this is one of those programs that we were able to achieve community-level outcomes on, and it was multiple interventions, multiple education and training led us to be able to do that. The next is our Menopause Training program, and I saw someone here works with residents, so this might be exciting to you because it's kind of incorporating continuing education before they've even graduated from GME. But through a needs assessment, we were able to, it was a national needs assessment that identified that residents received, in OBGYN residents, received very little training on recognizing the signs and symptoms of menopause. That they didn't know how to communicate to patients or were aware of what the treatment options are available to their patients. And we worked with our local hospital and found that the needs assessment was true for their particular program as well. So we worked with Paradigm, and the hospital is JPS, and we've designed a program for OBGYN residents at the hospital. The program includes an online module which delivers the clinical knowledge about menopause, and we considered that a part of the flipped classroom component of a design thinking workshop. The residents are then charged for coming up with a clinical decision-making tool, and we are actually having a competition. We're judging the tools to be able to determine which is actually going to lead to the best clinical decision-making for the residents and even for the clinicians and providers themselves. Our hope is that the outcomes will demonstrate improved satisfaction by the patients receiving treatment for menopause at the hospitals and the clinics, but one of the key components is that the education that's actually happening is mostly through the design of the clinical tool. They are actually having to put the pieces into it, and by selecting those components of the decision-making tools, they're learning about the decision-making process for diagnosing menopause. So it's kind of a cool approach to continuing education. And out of our office, we also do a lot of online education. So I just wanted to speak to a little bit of what we've done for enhancing our online module learning. And we incorporate opportunities to collect data within the module through embedded quizzes. We use Qualtrics, we use SurveyMonkey. We are working towards integrating Experience API, and that will help us collect additional data on our learners as they are making decisions throughout the learning module. When our practice identified that there were issues in the clinic staff filling out a form, we actually created the form within an online training module and had them practice how to create the form and fill it out correctly, and feedback was provided when a portion wasn't completed correctly. Choose your own adventure pathways can be very successful. They do require additional planning to be able to incorporate into online modules, but they can come in the form of testing in so that your learner is landing at a point that they may already have an awareness of a baseline knowledge, and you want them to focus on the new information. And case studies, again, are usually very important for that. The other thing for online learning is taking note of the adult learning principle that we are self-directed learners by nature, and we want to extend the education usually after we've completed a module. So really keeping in mind for providing infographics or resources, those references that can take a learner on a self-directed journey, and I like to call it a modified self-directed because we're definitely pushing them in a certain direction, but it helps reinforce and engage the learner. One of the things I didn't actually put on this is we also use a product that sends out reinforcement learning, and we can ask quizzes, we can ask or send out those educational resources to them following the activities. So with adding a reinforcement ticker every 15 days, every 30 days, we're getting them to revisit the material in a way that's convenient to them. And so then I have my innovation slide, but I already talked about it. So don't measure yourself against others. Really look inward and decide what your first step is. So I hope now you know a little bit more about the work that continuing education professionals do, and maybe even brainstorm one problem that you can work collaboratively on solving.
All right. Thank you so much, Dena, for that great presentation. I'll go ahead and stop sharing the screen now so everyone can find the chat box very easily. If you guys have questions for Dena, please go ahead and enter them in the chat box. She'd be happy to answer any questions you have about anything in today's presentation.
Thank you, Melissa.
So I do have one question for you, Dena, actually. That pyramid of the outcomes, certainly figuring out where you want to be, what is the best way? Do you guys do evaluation and assessment of like the patient health outcomes after a CE activity, or how do you go about doing that?
Yes, if we've designed the activity, we know that the outcome needs to be patient health level. We will design the activity to be engaged with the provider in a way in which we can observe their behavior and look at whether it be chart reviews or through the EMR, and then we'll take the baseline data prior to the intervention. And interventions can be, at that point, educational material or a workflow or change process, and then we'll evaluate the material at an appropriate interval. You really don't want to go less than 6 months because it's really hard to identify changes in patient care in less than 6 months. Most people typically don't revisit their provider that often, so it's difficult to examine a change in that short of time. 6 months is about the least amount of time you'd want to observe that level of outcome.
All right, great. If anyone else has any questions, we'll give a minute or so for people who might be typing their questions in the chat box. Possibly you had so much detail that no one has a question right now. And certainly if anyone thinks of any questions later on, you can feel free to contact our office and we'll be sure to pass them on to Dena if you guys do have questions later on.
Thank you, everyone.
All right, looks like there's no questions right at the moment, so I will go ahead and stop the recording if everyone could stick around just a little bit longer for our final housekeeping. But before we move into that, I want to give another big thank you. Thank you so much, Dena, for this wonderful presentation and for bearing with us for some of our technical difficulties. Thank you so much. Oh, yes, Dena did talk very quickly. I'll send out the link again to the presentation, and if Dena has any notes she'd be willing to share, we can certainly ask her and get in touch with her later.
Sure.
Oh, here we go. Here's a question. Can you speak to how to encourage activity organizers to achieve higher level outcomes? That's an excellent question.
That is an excellent question, and that's, again, why some of our competencies speak to leadership and all of those. I find that the process is really embedded, and it's, number one, finding your one champion who's willing to do it. Do the work, get the outcomes, tell the story. If you even have a tiny project that demonstrated the slightest bit of movement, I would get with your, if you have anybody who can work on marketing and really telling your story, because when you have that one story that people can profess greatness to, it will really start to motivate and ignite that change in others. And I would see what kind of meetings you could get, until you can get there, what kind of meetings you can get embedded and involved in, because so often, I don't know where your CE office is, but we have a joke among our industry that we're usually in the basement, and so you have to find those meeting spaces where they're talking about what to improve, how to get into that improvement cycle so that you can really get in the conversation early on to demonstrate how continuing education can be a part of the solving the problem. I've found success within our data informatics team. I found success within truly working a lot with the head of our clinical operations and just keep plugging away at being present so that you are remembered.
Great. Thank you so much for that question and for the fabulous answer, Dena. I will go ahead and stop the recording so we can get to our final housekeeping and get everyone out on time. So thank you, everyone, for all of your questions. And we'll answer any other questions via email. I think that's what we'll do for today.